It's a big challenge to start this session just before the lunch, but at the same time, we look at the importance of the topic and we expect all the audience to pay good attention to this topic. To talk about the children and the non-communicable diseases, we should all take back our memory many decades ago. We have come a long way. Let us imagine 5 decades ago, what did we hear about NCDs? We heard that NCDs are diseases, hypertension, diabetes, affecting the higher socioeconomic status. We used to call them fashionable diseases. And then we brought a program to screen. When we brought a program to screen, we also did a step survey. When we did a step survey, we find in Tamil Nadu, hypertension is about 34%, either single hypertension, single disease, or both hypertension, diabetes. And diabetes as a single disease is 17%. So we came to realize it is not related to the higher socioeconomic status, it is affecting the adults. Now, today's topic we are trying to talk about children predisposed for NCDs and also developing NCDs. A very important topic because it has its origin. What we see, the NCDs in the adults, it has its origin which can be traced back to their childhood. How do we look at this problem? And definitely type 1 diabetes, asthma, congenital and acquired heart disease, obesity, mental health disorders, they often become chronic when the child becomes an adult. To touch important statistics, can we believe 71% of the preventable adult deaths are due to NCDs. And that gives us the scope for prevention in adolescence. 60 to 65% deaths in India and Tamil Nadu, they happen due to NCDs. What do we do with the risk markers, especially among the children? In Tamil Nadu, 1 out of 5 are obese and 9.4%, about 10% are overweight. Children developing pre-diabetes, which can be reversed. Children with hypercholesteremia, which can be reversed or which can be intervened. Children with hypertension, children with pre-diabetes or diabetes, CKD, chronic kidney diseases. All these things are very important areas which we should look into. As the audience here, what are we going to do about prevention, early detection? How do we effectively manage this in their early years? Do we have a life course approach? Are we going to reduce the future morbidity and mortality and the cost involved to the health system? We have a lot of intersectoral applications in the field. School health program, RBSK, ICDS, Poshan, Pygmy, lot of things. What do we find? What is that framework we need to work out in an integrated manner to address this childhood NCD? This will be the forum to tell us how we think about this burden, what we are going to do in future. So now I invite the first speaker. Who's that? Dr. Abhishek, who is supposed to join us online. So maybe we can have the person, since he's waiting on online, he's one of our speakers. So let sir join and we welcome you, sir. Yeah. Can we have the video of the speaker opened up and ensure that he is audible and the screen sharing is perfect?
Can you hear me?
Yes, sir, we can hear you, sir. Welcome, sir.
Okay, thank you, sir. So, shall I? Okay, presentation. Okay. Thank you, sir. Thank you, respected Chair, Dr. Jerard, all the dignitaries and the panelists. I sincerely thank the organizers for giving us an opportunity, WHO, to be part of this very important and very important discussion on the NCDs in the children, and which is really the upcoming and most will be in the coming future. This will be the one of the topics which needs to be discussed all over the globe, and where the focus has to be made in terms of the policy decisions and the financing and the education and the behavior. So thank you again. So next slide, please. So if you see that we all know that about the NCDs associated with the adulthood in the adult population, where the India also the 30+ population where screening, diagnosis and treatment is being done, and Tamil Nadu is one of the leading in this area for the NCDs, NCDs management and the control. But now the focus has to be on the children and adolescents. Why? So there are some areas like cardiovascular diseases, chronic kidney diseases, type 1 diabetes, type 2 diabetes, asthma, cancer, metabolic condition, other conditions where we see the more than 2.1 billion children and adolescents are affected by NCDs in 2017, and more than 1 million deaths in children under 20 in the 2017. This is a very high number, and this is increasing year by year. So if you see in terms of the 1.2 million people aged under 20 years dies from non-treatable NCDs, which can be treated, which can be prevented, but there is a death of more than 1.2 million. And 24.8% of Delhi's and 14.6% of deaths among the children and adolescents. So I'm giving this figure because this is alarming, and it's an alarming situation where we all stakeholders need to come together, policymakers need to come together, and all the partners to come together to build some sort of planning for to tackle this burden of NCDs among the children. And if I give because WHO is working on the estimates on the childhood cancer burden, and I'm part of that. So if you see this, giving some rough figure on among the children aged 0 to 19 years, the childhood cancer is a leading cause of deaths and ranks 4th in the global disease burden. So I'm just giving an example. Other diseases are also very important. Type 1 diabetes, type 2 diabetes, cardiovascular disease are very important. And if you see in terms of the childhood cancer, again, approximately 90% of new cases are diagnosed in LMICs, and it is estimated that up to 43% of cases remain undiagnosed worldwide. So these are the figures which is really brings with the policy makers to discuss and decide, and this is the one of the forum. I thank again the organizers for coming with this discussion. And if you see there's an article that says that the estimate 70% of premature deaths in adults can be linked to the behaviors that start in adolescence. So this is the global burden, which increasing burden among the NCD children with various areas, various diseases. Next slide, please. In terms of India, I see that India has the highest number of children and adolescents living with NCDs in the world. So the numbers are increasing in India year by year. And if you see that more than 27 million children and adolescents are living with severe or debilitating NCDs by 2021. So these data show. But if you see the second part of this, that 3.4% of children there is a childhood obesity. But this is the childhood obesity. If you see the overweight is more than that, so that can be a obesity again. So the numbers are growing. Diseases are growing. This is a time to work together for the prevention and the control of the NCDs of the children. And more than 4 million cases of these severe NCDs are being added every year in this age group. And this impacts the children and adolescents, all age groups of the children and adolescents, where the adverse impacts on the child's social and academic development, mental health issues are there, comorbidities are there, out-of-pocket expenditure of the family, and the expenditure on the government, on the policy makers are there, impact on the economic productivity, and significant future burden and cost for public health. So this is the India scenario. Next slide, please. So there is a need. If you see the current 2011 census, so there is around 30% of population living in this age group. And if it is not tackled, so if you see the projection population of 2036, it's going to grow, it's going to increase in all areas if it is not prevented now, if it is not tackled now. So it is going to grow in all the age groups of the children and adolescents. And children affected by NCDs often face a lifelong challenge, and we all are aware about the societal issues and other issues in terms of how the children are facing the NCDs among this age group. So this requires a multi-sectoral approach. If you go to next slide, please. So if you see that it is not a foolproof strategy, and this is a thought how we can in the existing system. Tamil Nadu has a very good system of NCDs. They have MTM, they have other systems are there. So building on those adulthood, managing the adulthood NCDs can be come together for the childhood NCDs also. Like the areas for the health promotion and prevention of the risk factors, we know that prevention is the more important in this age group. So promote healthy eating habits, encourage physical activity, prevent tobacco and alcohol use, and there are other areas also. And there are the contributing factor where we need that community environments and environment health promotion. And of course, most important is the mental health promotion, mental health area where needs to be, the focus has to be there. And there are other areas, strategies which can become as one of is the strengthening of health systems, NCD clinics, and the primary care health, early diagnosis and management. We always talk about adulthood, the early diagnosis and the treatment is the key to save the life of the people living with NCDs. Here also the early diagnosis and management is key, and linkages with other existing programs. So can you go to next slide, please? So this is my last slide, and this is a very, you can see that there are many areas where can be linked, and all the multi-sectoral areas, multi-departments have to come together. It is like a RBSK is there, RKSK is there, maternal and child health, school health program, nutrition program, tobacco control program, oral health, NCD program is already there, Department of School and Education, Reproductive Maternal Neonatal Health, Child and Women Development, and Sports Ministry. So there can be much more. So what I am trying to say here that the multi-sector and multi-collaborative approach will be a very helpful in tackling the NCDs in the children, which is growing and increasing day by day and year by year. Thank you very much for again, Chair and all the dignitaries and panelists and organizers for giving WHO an opportunity to speak. Thank you very much.
So thank you, sir. When we sum up, we will be taking up some important highlights. Call upon Dr. Pradeep Kumar, Director, Health Systems Research India Initiative, Kerala, to share your experience on this important topic.
So good afternoon.
Volunteers to ensure that all our medical officers are inside, because it is very important topic for all our medical officers. Please encourage each other to be present inside.
Directing to the here itself. Okay. So good afternoon to all the dignitaries on and off the dais. And I have a great pleasure in coming and talking to you, and I express my thanks and gratitude to all the organizers and also to UNICEF for giving me this opportunity. So I am coming from Kerala, and Kerala is also a state with a high burden of NCD. And almost 2/3 of all deaths in these years are due to NCDs. And in 2016, almost 4% of all NCD deaths occurred in Kerala were among people below 30 years of age. We all know the causes. Exposure to risk factors, especially the modifiable risk factors like tobacco use, alcohol consumption, air pollution, unhealthy dietary practices, and physical inactivity are the major causes. And the people are exposed, and the newborns are also exposed even before birth, prenatal exposures, natal exposures, postnatal exposures and exposure throughout the life are the are the situations in Kerala and also elsewhere the country, and these are the grave situations. So let me quote 3 recent studies from Kerala to substantiate this statement. So one study conducted among adolescent students in higher secondary school in Kasaragod revealed multiple risk factors among them. The consumption of packaged food and soft drinks were very high, 67% and 90% respectively. The consumption of fruits and vegetables required for the day as per the WHO recommendations were less, only 49.4% were taking this much fruits and vegetables. And the physical activity as per the recommendations were also low, only 41.9% were physically inactive. All these things resulted in overweight, obesity. 13.2% of them were overweight, and there were high clustering of risk factors. They studied 8 risk factors, and 34.7% had 2 risk factors, and 21.7% had 3 risk factors. And another study among adolescents in higher secondary schools in Thiruvananthapuram that also showed almost similar pattern, and the prevalence of hypertension among them were 25%, overweight 19%, and obesity 6.4%. This is not the adult population. In Kerala, among the adult population, almost 20% are suffering from diabetes, and more than that, 20% of others are in the pre-diabetic state also, and almost 30% are hypertensive, and 25% are in the pre-hypertensive stage. So that is alarming in the adult population, that usually leads to very high numbers of renal failure, cardiac deaths, and stroke events. But you see, even among adolescents, the hypertension, overweight, and obesity are very high. The other risk factors are also high. Consumption of junk food and soft drinks are 63% and 53.5% respectively. Consumption of fruits and vegetables at least 2 to 3 times a week in sufficient quantity is less, 54.5% and 31.8%. Physical activity was also less, 38% only. And another study conducted in the among the college students in Kannur also revealed the similar results. What we can do, the strategies should be started right from the childhood itself, and the strategies can be at the micro level or at the macro level. Some of the risk factors, most of the risk factors are related to dietary factors and also physical inactivity related factors. So the need of awareness generation is good, and making the healthy food choices available, affordable, and accessible are more important than awareness generation. And also about the physical inactivity, the situation should be suitable for promoting sports, games, and other physical activities are useful. But these voluntary control measures through awareness generation may be usually unsuccessful, especially in large populations. Legal measures and policy formulations are more important in such situations. Such measures are available and are cost effective also. Let us see some of them. Before going to that slides, let me narrate some of the pilot studies we have conducted in Kerala with the help of the NGOs like Kerala Voluntary Health Society in coordination with the VHI, Ministry of Education Kerala and Kottayam Municipality. We have conducted some pilot studies in 5 schools in Kottayam and included students studying from 6th to 9th standard. About 800 students participated in the study, and it was the Healthy Tiffin Box campaign. The objective was to upscale the nutrition intake of students, to prevent childhood obesity, and to create awareness about the junk food and trans fat. So the activities, the parents, teachers and students, leaders were sensitized about the risk factors and the results in the adult life, and the health education classes were given to the students. Dietitian also talked in the classes, and the dietitian helped the students and parents to modify their health, food habits, but they modified it in such a manner so that every family can adopt it easily and affordably. For example, if the child is coming with a bread, the dietitian worked with them and asked them to add some fruits and vegetables along with that. The children coming with sweet, the dietitian advised them to take other foods without any sugar, something like that. So they created this awareness, and a sticker campaign was also conducted along with that. Then another one was, along with that, healthy corner were created in the schools to establish a space for health in schools and to develop health as a subject for extracurricular interventions. So created a space as a resource center in these schools, and provided reading materials, IEC materials, posters, etc. in that resource center, so that the students can come at any time and can read and get information. Then there were health talks also. So all these and also another thing, in small scales, traditional game promotion activity was also conducted in these schools. So finally, the result was in the initial stage, almost 60% of the students were bringing unhealthy food. At the end of 6 months intervention, this reduced to 20%. Then other interventions like tobacco-free home initiatives, tobacco-free school initiatives, school protection committees were also there during the. So there are policy options like that, but because of the positive time, I can brief it in, make it a brief. So develop policies to reduce children's exposure to ads and marketing of unhealthy foods and beverages. Tie up with the food industry for reformulation of packaged food and beverages with less fat, sugar and salt contents, and make them widely available at a lower cost, and the government can give subsidy or incentives. Restrict the sale of unhealthy food to reduce the impact of children, like reduce the frequency of dissemination through electronic and print media, reduce the power of messages, and avoid dissemination before the bedtime of children, and restrict the advertisement in all settings where children frequently visits, like schools, parks and children's shops, etc. Improve the food labeling, especially the FOP, front of package labeling and traffic signal packaging will be more helpful also. So because of the positive time, I stop here. Thank you very much. Thank you all.
Thank you, sir. I request the speakers to stick to your timing. It will be helpful for everybody. And all the block medical officers, DTTMO and other APMs, we look forward to some questions at the end from you, because medical officers' attention is very, very important for this session. So as I said earlier, the Salem district organizers, please get in touch that people, even if they are a little out, can be called inside. Now I invite upon Dr. Raghunanthanan sir, Director, ACS Advanced Medical Research Institute, Chennai, to deliberate on this topic.
Good afternoon, most respected Director of Public Health and other higher officials of Directorate of Public Health, and also respected dignitaries on the dais and off the dais, and friends. We are conscious that we are standing between you and lunch, and as the moderator already said about the time management, I am also for it. So I'm not going to project any slides, but just I want to share some of my thoughts on this very, very important topic. Before I go to the topic as such, I should really congratulate the Director of Public Health for taking up this topic, because this prevention of this NCD can be discussed only in this forum. In no other forum we can discuss. We only talk about management, complications, high-end investigations and treatment, transplant, like that. But I think we should congratulate the Director of Public Health and Director for choosing this topic, because normally when we say DPH, we only focus on communicable diseases. But now the time has come to focus on the NCDs also. So with that small introduction, I view the topic in a different perspective, because the topic talks about prevention of NCD in adolescents, children, like that. But there's one beautiful Tirukural all of us know, Noi Nadi, Noi Mudal Nadi, Adithanikum, Vai Nadi, Vaipachayal. Normally we tell this for fever outbreaks. Whenever a patient comes with fever, find out what is the cause of fever and manage. But today, when you are talking about NCD, today we have a program of walk-in. Anybody who walks into a PHC 30 years plus, you are being screened for a non-communicable disease like hypertension, diabetes and other things. 18. Okay. So, we are screening them at the age of 18 years. But all of us know, once we understood the etiopathogenesis of all NCDs, it starts from utero. So, when you are talking about prevention, we are not only talking about prevention of NCD in childhood, we are talking about prevention in adulthood also. I think that is the most important, because as a parents, as grandparents, we want our children to have a healthy life. But none of us conscious of their health related issues starts in utero. So starting from pregnancy, we already know the subject, so I'm not going to the nuances. But starting from utero, and one of the major points that I want to take up for discussion is obesity. I think obesity is a risk factors or a risk factor for most of the non-communicable diseases, including cancer, diabetes, hypertension, and today we are talking about metabolic associated steatoliver disease like NASH. So everything starts with your diet. So I want to concentrate on two important components. One, my previous speaker has already shown so much of evidence about junk foods, because they say, because we are all addicted to the taste. Even if you go with so much of motivation not to take ice creams when you go for a party, the smell and the sight makes you to take it, because we are addicted to that. So I want the younger generation to be conscious. Still I remember when I was in GH, one of our professor used to say, he is a diabetic. He will say, when I go to a party, when I see a laddu there, my mind says, please take it. But again, my subconscious mind says, if you take one laddu, you have to do another 10 minutes of walking tomorrow. So he has to choose whether to take one laddu or take another 10 minutes of walking. Ultimately, he decided, I don't want to strain more, so I will not take laddu. So what I'm trying to say is, it's nothing but your mindset. So make sure that all our kids are told about all these impacts at childhood. Ilamayil kal, and also they say Tottil Padakam Idugadu Mattum. And also there's another, all these are Vidai Vidaitavan Vinay Arupan. If you take, in fact, one more thing, they say God has given you, say 10 lakh units of insulin. It's up to you to use it throughout your life. Human life is meant for 120 years. That's what they say. But how you protect yourself, how you use your health, or you use your diet, use your exercise judiciously, will make you to survive for a long time. So that is one thing that I wanted to tell regarding the modifiable factors as far as NCDs are concerned. Other is the non-modifiable factors like genetic disorders. I think one of the important programs that we do in our state is screening for thalassemia and sickle cells. In Jabna Mathur already the program is going on. So we can identify certain high-risk places where non-communicable diseases through genetic or other inborn errors comes. We can have a structured screening program for those high-risk groups that can be done. That's one more. And another non-communicable disease that is being commonly screened in our program is on thyroid disorders. I think all the newborns are being screened for thyroid disorders, and all pregnant women are being screened for thyroid disorders. We have a structured program so that thyroid is being already taken care. And another important problem as a social responsibility is drug addiction. Today, I think the drug addiction starts in childhood, in schools. So I think that's a very big problem. Unless we address them that day, that level, we are going to face complications later. So one, and another is using mobiles and social medias, sleep deprivation. I think another common, because most of my students, they come late. They say, I go to sleep only at 2 a.m. because of the social media and other things. So there are many more like your, what should I talk about? The environmental, already air pollution was discussed. That has to be addressed. And before I conclude, I want to include one more thing. Today we go and get checked for cholesterol, creatinine, LFT and other things. Now the time has come to check your microplastics in your blood. Already articles have started coming of doing a microplastics. We consume roughly around some 10,000 particles, 10 to 20,000 particles per year. That's what we are consuming, microplastics in one, and we are able to detect the microplastics. So be aware of using all these bottles. Even other things like your Dept. Dept contains plastics. So like that, please go through the articles on microplastics. So there are many areas which are acting as a triggering factor for non-communicable diseases in our life. So please take care of them. So before I conclude, just I want to tell 3 important components. Begin before birth. Starts with antenatal and your life changes. Continue after birth. Be aware of your diet and exercise. Make it a habit till death. At last, it matters is your health. Thank you.
Thank you, sir. I admire sir for quoting a lot of Tirukkural and other important quotes. One quote he mentioned was, Yagavarainum na kavakal soga appar sollirukkupatte. Poduva ellame நம்ம அந்த மற்றவங்களை ஹர்ட் பண்ற வேர்ட்ஸ்க்கு தான் நம்ம நினைப்போம். ஆனால் அவர் சார் நாக்குக்கும் சொல்லியிருக்காரு. அதாவது நம்ம உணவு உண்ணும் பொழுதும் அந்த நம்முடைய நாவை நம்ம காக்க வேண்டும் என்ற ஒரு டிஃப்ரெண்ட் இன்டர்பிரிட்டேஷன் கொடுத்துருக்கீங்க சார். தட் வாஸ் வெரி இன்ட்ரெஸ்டிங் டு அப்சர்வ். Next we call upon Dr. G. Prakash, HOD, Department of Diabetology, Government Medical College, Salem. Welcome, sir.
Good afternoon, one and all. At the outset, I thank the scientific committee for inviting me here. So they are calling a diabetologist during hypoglycemic period. So we are in the era of non-communicable disease. So how to prevent? Communicable disease prevention is very easy. We have given vaccine and we have done everything. But now it is a tremendous task for the public health department in prevention of this NCD. So this is a concept wherein we need to say that the prevention starts pre-conception even. A young adolescent woman should maintain her ideal body weight. She should not be overnourished or she should not be undernourished. Both undernourishment as well as overnourishment causes non-communicable disease. Why? Because the undernourished, when they give birth to low birth weight or poor gain in weight during infancy, when they are succumbed during adulthood or during childhood to excess consumption of food, that causes diabetes and other metabolic disease. Why? Because undernutrition causes poor beta cell development, so they could not cope up during the childhood and adolescence. Similarly, nourishment causes obesity and overweight, which strains the beta cells in the utero even. So we need to prevent both undernutrition and overnutrition. Then this is a concept called fetal origin of adult disease. The left hand side you see, this is David Barker. He had done a retrospective study. He collected all the data of those who had NCD, and he had gone to records of their birth. He found that those who had a low birth weight or poor nourished developed diabetes and metabolic disorder and cardiovascular event. Similarly, Chittaranjan Yajik is doing a prospective study in Pune, wherein he started collecting data from the birth and is following up almost 10 to 15 years. He found that those children who had born low birth weight and poor gain in weight has an increased incidence of this metabolic disease. So early fetal intervention is a must. Optimization of maternal nutrition is very helpful in prevention of diabetes, and control of maternal hyperglycemia is very much essential to prevent the metabolic as well as cardiovascular disease. And another important thing is maternal weight management is important. So periodic weight assessment helps in producing the good healthy baby. And another important thing is encourage exclusive breastfeeding. That itself has found in few studies prevention of development of type 1 diabetes. And we need to delay the weaning foods, complementary foods, later part. So what are the risk factors in children? Unhealthy diet, which is very much rampant. And next is physical inactivity. And recent study for our officials, you should not sit idle for more than 2 hours. You need to break. So that itself causes diabetes in future. So break your sedentary sitting time not more than 2 years. Then obesity is another risk factor, environmental exposure, and the mental stress what the children are having, the academic pressures. So don't stress the child. Now most of the school are stressing, has started IAS course from 6th standard even, and this NEET course from 8th standard. So don't put pressure. That is also a risk factor in children. And family history, this is a non-modifiable risk factor. Then we need to detect early. How? Based on the growth chart and periodic BMI monitoring. And blood glucose and lipids in overweight child. So the primordial prevention is promote healthy diet from childhood, enhance physical activity. One of the important factor that we need to do is limit screen time, because almost most of us are with the cell phone. So we need to teach the children to restrict the screen time, and school-based health education is very much important. And another important thing is we must ask the teachers not to give excess homework. That itself disrupts the metabolic life of the child. So sleep hygiene is important, and reduction of mental stress. This is the CBSE has mandated these boards has to be kept in all CBSE affiliated schools, sugar boards, wherein they are promoting not to take these high calorie drinks. So this must be also be included in our Tamil Nadu government. So a brief word about diabetes occurring in childhood. All diabetes occurring in children are not always type 1. There are other types even. Although type 1 diabetes is common, we need to also focus on other classification of disease. Type 1 diabetes usually starts between 6 months to adults, and it presents acutely, and you could not trace the family history in type 1. Obesity is rare in type 1. Acanthosis nigricans is a marker of insulin resistance, which is not there in type 1. And most of the person present with high blood sugar and DKA. And autoantibodies are positive in type 1. Whereas type 2, it do occur in overweight and obese children, wherein both of the family members will have diabetes, and obesity and overweight is a common feature of type 2 diabetes. Acanthosis nigricans will also be seen glycemia is variable, autoantibodies is negative. And another important is we come across is maturity onset of diabetes young, which is also not that much common, but we need to study that. And it is incident, and one parent lineage will have diabetes. For example, if the child father and father's father may be diabetic. So one single lineage, that is autosomal dominant inheritance. And how to diagnose type 1 diabetes earlier, that was our moderator's question. So there is no specific factor to detect type 1 diabetes early, but we can detect based on the weight measurement. Similar to progress card, we must ask the school teachers to maintain weight card. Every month they need to assess weight. So periodic weight assessment itself helps in detecting diabetes. How? Why? Because it is a rapid loss of weight is a feature of type 1 diabetes. Similarly, overweight is also a marker of diabetes. So these are all the various stages, wherein in stage 1 it's very difficult to pick up. In stage 2 we can pick up. Now there are drugs in preventing the stage 2 progression to stage 3. So we need to primarily prevent the maternal and early life intervention, healthy lifestyle promotion, and environmental measures promoting outdoor activities. I like the public health officials not only give sanitation certificate to the schools, but also active playground certificate. Thank you. Thank you very much for your patience hearing.
So thank you, sir, for a lot of valuable inputs. We will come back to the summing up. Next, I call upon Dr. K. Krishnaraj, Joint Director, NCD, Directorate of Public Health and Private Medicine, to share his views.
So, good afternoon. ரொம்ப கஷ்டமாக இருந்துச்சு. நவ் ஆன் ஐ எம் ஹைப்போக்ளைசிமிக், ரைட். 12:30 மணி பேசுறது, 2 மணிக்கு நம்ம சாப்பிடாமல் பேசுறதுனால ஐ எம் இன் ஹைப்போக்ளைசிமிக். பட் நான் ஆரம்பத்தில் கொஞ்சம் கஷ்டமாக இருந்துச்சு. நீங்கள் எல்லாம் எல்லா சேரும் வேக்கண்டாக இருந்துச்சு. யூ ஆர் ஹேட் எ குட் கிளைசிமிக் இண்டெக்ஸ். நல்லா சாப்பிட்டு நிம்மதியாக வந்து உட்காந்துருக்காங்க. ஸோ நம்ம கொஞ்சம் கஷ்டப்பட்டு பேசணும். நீங்கள் இஷ்டப்பட்டு கொஞ்சம் சில பாயிண்ட்ஸ் எடுத்துங்க. ஃபஸ்ட்டு ஸ்லைடு போடுங்க. பேர்டன் சொன்னாங்க. ஒரு படம் முடிஞ்சோடனே யூ சி த 5 மூவி, ரைட்? ஆல் ஸ்டோரிஸ் ஆர் ஓவர். ஸோ ஐ வாண்ட் டு ஸ்பீக் 1 or 2 இம்பார்ட்டன்ட் பாயிண்ட்ஸ் வித்தின் எ 5 minutes. பேர்டன் அப்படின்னா எல்லாருமே தே ஆர் சேடன், பேர்டன் அண்ட் ஸ்டடி அண்ட் ஆல் திங்ஸ். ஸோ we are screening above 18 years NCD. As a NCD JDங்கிற முறையில் we are concentrating more 4 years. We are achieving detecting hypertension, diabetes, both and CSRX and all things. We are achieving 2,47 lakhs line list maintained only in Tamil Nadu compared to throughout India, right? That is our achievement. But sir exactly says this topic is chosen. Thanks sir for DPH for this topic. We should concentrate the screening from 0 to 19, right? That is the point. And also sir exactly mentioned the before marriage, after marriage. So we are having more tools, more portals from various departments, from the geriatric, MCH and RBSK and NCD for MTM, so many portal, right? பல portal வச்சுருக்கோம். ஒன்று தனித்தனியாக பீஸ் மீலாக வச்சுருக்கோம். பட் நாட் மேட்சிங், நாட் fetching, not able to ourselves by clutching, right? So output is different, right? So that is our worry. But childhood prevention is the most cost-effective life course of strategy for the NCD. So we are missing in Tamil Nadu. Acceptance is the administration, right? Next. Current state மக்களை தேடி மருத்துவம் இன்னும் வெரி வெல் அபவுட் எல்லாருமே வந்துருக்கீங்க. விஹெச்என் வந்துருக்கீங்க, ஹெல்த் இன்ஸ்பெக்டர் வந்துருக்கீங்க, மெடிக்கல் ஆஃபீஸர், பிஎம்ஓ, ஆல்ரெடி அடிஷனல் டைரக்டர் செய்யும், மெடிக்கல் ஆஃபீஸர் ப்ளீஸ் செட் சொன்னாங்க. மக்களை தேடி மருத்துவத்தில் ப்ரோஸ் தெரியும், கோன்ஸ் தெரியும், கேப்ஸ் தெரியும். ஈவன் தோ ரெசிலியன்ஸ், வி ஆர் ஏ ரெசிலியன்ஸ் பப்ளிக் ஹெல்த் சிஸ்டம். என்ன அடி வாங்கினாலும் நாணல் மாதிரி நம்ம டிபிஹெச் சொன்னார். வி ஆர் அச்சீவிங் 2.47 crores. ஸ்கூல் ஹெல்த் ப்ரோக்ராம் அவர் பார்த்தீங்கன்னாக்கா ஆர்பிஎஸ்கே சோமசுந்தர் சார் பார்க்குறாரு, அது தனி போர்ட்டல் வச்சுருக்கோம், ஆர்பிஎஸ்கே போர்ட்டல். இன்னொரு பக்கம் எமிசிஸ் அப்படின்னு ஒரு போர்ட்டல், அதில் பிஎம்ஐ செக் அண்ட் ஆல் திங்ஸ், ஆல் விஆர் என்டர்ட் ஆல் திங்ஸ் இன் த போர்ட்டல், ரைட்? அது இருக்குது. எஜுகேஷன், ஹெல்த் எஜுகேஷன், அதில் வி ஆர் மிஸ்ஸிங் ஹெல்த் எஜுகேஷன். சார் ஆல்ரெடி கேரளா சார் saying so many studies. ஹெல்த் எஜுகேஷன் வி ஆர் என்னமோ கொஞ்சம் வி ஆர் மிஸ்ஸிங் நம்ம தமிழ்நாடு அப்படின்னு நினைக்கிறோம். இயர்லி டிடக்ஷன் கன்ஜெனிட்டல் என்சிடிஸ்க்கெல்லாம் ஆர்பிஎஸ்கேல இருக்குது. ஐசிடிஎஸ் ஒரு பக்கம் இட்ஸ் எ பீஸ் மேல். ஐசிடிஎஸ் தனி போர்ட்டல், செப்பரேட் போர்ட்டல், என்ட்ரி கலெக்ஷன் ஆஃப் டேட்டா இஸ் செப்பரேட், இஸ் எ பீஸ் மேல். மிட்டேல் இன்க்ளூடிங் டொபாக்கோ ஃப்ரீ ஸ்கூல் நவ் இஸ் எ சேலஞ்சு. சார் இஸ் தூங்க மாட்டேன்றாங்க, படிக்க மாட்டேன்றாங்க. அவர் சார் சொன்னார் ஸ்கூலில் வந்து டொபாக்கோ கோட்பா 2003 கோட்பா இஸ் எ சேலஞ்ச், இஸ் நவ் சேலஞ்ச். ஸோ என்சிடி இஸ் two main factor. One is stress, adrenalism. அம்மா, பார்ட்னர், ஃப்ரெண்டு, டீச்சர். டிபிஎஸ் சொல்லிக்கிட்டு இருந்தார் பேசிகிட்டு இருக்கும்போது, இதெல்லாம் ஜெனட்டிக் கவுன்சிலிங் வேணும் முன்னாடி. வி ஆர் மிஸ்ஸிங் ஜெனட்டிக் கவுன்சிலிங், மிஸ்ஸிங் பிஃபோர், டூரிங், ஆஃப்டர் மேரேஜ் ஜெனட்டிக் கவுன்சிலிங். அதே மாதிரி சார் சொன்னாங்க இன்சுலின், mother insulin we should monitor 8th week onwards. We are missing after birth 0 to 6 year. ICDS merging of ICDS RBHK data with NCD. கடைசியில் பார்த்தோம்னா NCD JDக்கு வேலைன்னு பார்த்தீங்கன்னா JDMCH, அப்புறம் JDHP, அப்புறம் எல்லா JD டேட்டாவையும் ஒன்றா வாங்கி போட்டு we should extract the output. அதை எடுக்கணும். ஹவு டு ஃபார்முலேட் த நெக்ஸ்ட் எஸ்ஓபி ப்ரோட்டோக்கால் எப்படி டெவலப் பண்ணணும், கொஞ்சம் பயமாக தான் இருக்குது. நெக்ஸ்ட் திஸ் ஆர் கரண்ட் சிஸ்டம் லெவல் சேலஞ்சஸ். பார்த்தீங்கன்னா எம்டிஎம் டீம் இப்போ சேலஞ்சஸ் அதிகம் இருக்குது. மேன் பவர் சேலஞ்சஸ் இருக்குது, ஃபைனான்ஸ் சேலஞ்சஸ் இருக்குது. ஸோ அதெல்லாம் ரொம்ப இருக்குது. ஃப்ராக்மெண்டட் டேட்டா பேசிட்டோம். அர்பன் ரூரல் இஸ் எ சேலஞ்ச். என்சிடி அர்பன் ரூரல் மோஸ்ட் ஆஃப் த ஸ்கூல்ஸ் பேஸ்ட் அப்பான் த அர்பன். அதே மாதிரி நம்ம ஆர்பிஎஸ்கில் பார்த்தோம்னாக்கா நம்ம வந்து we are concentrated on the government aided school. We are not able to concentrate on the private school. Private school தான் obesity. அவர் சொன்னார் 3.5% obesity most in the private school. government aid எல்லாம் நம்ம கான்சன்ட்ரேட் பண்ணுறோம். பிஹேவியரல் ரிஸ்க் இப்போ வந்து பிஹேவியரல் கம்யூனிகேஷன், சோசியல் பிஹேவியரல் கம்யூனிகேஷனே நம்ம we are not concentrated. Only collection data, compilation of data, analyzing the data, then preventive measure, control, elimination, eradication. We are not concentrated the primordial preventions. Thank you for this topic. Right, next. No, 2 more slide. That's all. Opportunities. எல்லாமே இருக்குது நம்மகிட்ட. ஆல்ரெடி தமிழ்நாடு ஹேவ் ஆல் டேட்டாஸ், ஆல் ஹெச்ஆர்லேருந்து போர்ட்டல்லேருந்து எல்லாமே இருக்குது. மல்டி செக்டர் கொலாபரேஷன் இருக்குது. But integrations, sir சொன்னார் integration is poor. I feel the integration is poor. So on the digital tools, so we should modify the separate digital tools. NCD tool is enough for the monitoring all categories of MCH and all things. Community awareness should be created for the primordial prevention from birth to 19 years is very more. Next, opportunities there, recommendations. Already sir exactly says life course approach, maternal, child and adolescent is must integrate. Already discussed equity. The equity is a challenge. Urban rural system is very challenge. So we should prepare for that in Tamil Nadu. Monitoring and review. Very good review system, sir. We will integrate. After integration, extraction of this childhood data and all things, we create a tool for the review mechanism. Next. So, எல்லாமே இருக்கு நம்மகிட்ட. We are doing hard work, but we are missing primordial prevention. This is the only platform, the first platform Tamil Nadu to for all. Thank you, sir. Thank you for this time. Thank you.
Now there will be a moderation by Dr. Kaushik. He will focus the questions, specific questions.
So, maybe the panelists, thank you for the very elaborate presentation and the discussion. And the advantage of having a high-powered panel is that most of the questions are already answered. So it's going to be mostly a little bit of repetition. I will go to Dr. Abhishek Kunwar from WHO first. Dr. Abhishek, can you hear me?
Yes, sir. Yes, I can hear you.
Yeah. Thank you so much for being a patient listener. So, from the global perspective and from WHO's global experiences, we know Tamil Nadu has had, as Dr. Krishnaswamy mentioned, Tamil Nadu has a very robust community level screening program. They have almost line list of 2.5 crore people being screened and for NCDs and also given drugs, free drugs. From your experience, is there any learning from the global level or from national dispensation on how to better integrate NCDs or early onset NCDs into the program, into the community level program, and what kind of policy shift is needed for us to move that needle forward? Over to you, Dr. Abhishek. So my question is, what are the key learnings in the space of policy reform or community level engagement for early onset NCDs or NCDs in children? If you can throw some light on that, that would be great. Dr. Abhishek, we can't hear you.
Can you hear me?
Yeah, we can hear you now. Yeah.
Thank you. So, thank you again for the question. And what I want to mention it here that there are a couple of examples from global on terms of the NCD in children school health programs and other programs related to the childhood NCDs. But having said that, and you have mentioned about the Tamil Nadu example also, Government of India, Ministry of Health, and in terms of the NCDs for 30 plus population, there is a very good population-based screening is there, existing there for hypertension, diabetes, and three cancers. So particularly if you talk about the hypertension and diabetes, India has been a champion in terms of the screening, diagnosis, and the treatment, and providing the medications at the households and medications at the primary healthcare, Ayushman Arogya Mandirs. So India has received many acknowledgements from globally in terms of the managing the adulthood hypertension and now in the diabetes area also. So now coming to the NCD in children, my thought is that building on the existing infrastructure of the screening program and integrating into the existing child health platforms, that will be the one of the area where we can India focus on. And there has to be task shifting with the focus training and the job aids for the training of the community health workers and the other medical professionals. So that will be the other area where this can be leveraged based on the national experiences. If you talk about the global experiences, I think Vietnam has a very good example for the school-based obesity program, where they have done the randomized control trial. And the key lesson from is that effectiveness of the modifying school meals and nutrition education, which we have just many of the speakers, the dignitaries, and they have talked on in this area. So how to modify the school meals and the nutritional educations and combining this with the physical activity and involving families and the teachers. So the Vietnam has done one of the key intervention in this area, which can be learned from the global example. Okay. Also, if I talk about the WHO Pen Plus, when UNICEF is also involved, and particularly in the Africa, which brings the which brings the NCD care very closer to the needs of the underserved populations, and the training to the physicians and non-physicians for the management. And many of the African countries which are showing this, leading this, and the UNICEF and WHO are working together with those countries to build this capacity with the Pen Plus strategy.
Okay.
Ghana has examples. We can discuss all that. But more importantly, there are some examples from the Brazil is there for healthy habits in action in schools. So bringing all these global examples and bringing the current Indian strategy for the NCD management at the community level, school health programs, bringing all the multi-sectoral, multi-departments together to build a uniform system of managing and tackling the NCDs among the children. I think that will be the one of the great, one of the ideas which can be put forward. So this is all from my side. Thank you.
Thank you so much, Dr. Abhishek. I think the key message that I got is that there needs to be a better integration between child health and the NCDs program. So that is how we can integrate the different platforms where child's touch point is. So I will go on to the next, Dr. Pradeep. Dr. Pradeep Kumar from HSRII. You have recently done a study on urban health, and it would be great if you can throw some light on what kind of key challenges in urban health centric challenges do you see in managing risk, identifying risks and managing risks with respect to early onset NCDs in the children? Yeah, it's okay.
In urban centers, actually in Kerala, the urban healthcare services started recently, especially for the non-communicable disease services, and it is mainly working for on clinical nature, and they are providing medications, testings, and all these are free of cost. So it is more popular, and a lot of people are coming there because it is so free and everything is available, and it is less difficult than going to secondary and tertiary care centers. But though I have visited several urban health centers during my recent study, I could not find much public health activities in the primary health center, in the urban health centers. So they are trying to get more funding, support, and technical guidance also.
Right. So yeah, technical guidance and perhaps better protocol for integrating NCD related public health activities in the primary healthcare giving setting.
Actually, they are doing some health education sessions in the class, in the schools, occasionally. Right. That's all.
Right. Thank you so much. I would move on to Dr. Prakash. If you spoke about the low birth weight babies being more prone to developing NCDs later in life, and I was actually referring to Dr. Chittaranjan Yagnik's recent paper, yes, on how visceral fat, children tend to accumulate visceral fat, children low birth weight and towards the lower spectrum of the birth weight children tend to accumulate more visceral fat and are more prone to developing diabetes and NCDs.
Yeah, low birth weight, they have a poor development of beta cells.
Right.
And when they succumb to environmental exposure, to higher food intake, the visceral fat gets stored. So insulin resistance increases. So the poor beta cell function at the fetus cannot cope up with the nutrition they are taking. So that's why the low birth weight and preterm are more prone to develop diabetes.
So my question is, if I were to ask, request our frontline workers to give 2 to 3 messages, key messages to the parents of low birth weight children, what would those 2 to 3 messages be?
To the antenatal mothers.
Antenatal as well as postnatal mothers.
Yeah, whoever it might be, adult mother or in reproductive age group, we must guide them to maintain a good lifestyle with appropriate BMI and avoid sedentary or active lifestyle. That itself will help, and also to take micronutrient supplements if they are undernourished.
Okay. Thank you so much. A very related question to Dr. Raghunanthanan, you sir. So following from Dr. Prakash's submission, I wanted to check with you, what kind of parenting advice do you think we should give to a parent who has been detected with, whose child has been detected with NCD or early onset NCD, and how do we operationalize a life course approach for such a child? We
Okay.
have been speaking about life course approach. Many people of
Yeah,
many
yeah,
of you.
I do understand. In fact, as all of us have agreed that incidence of obesity is increasing, and when you go out today in the community, we see so many children are obese, and even to tell the parents about their diet modification, they may take it in a different way.
Right.
But I think today we should identify the influences of children. I think the first influence starts from family. So parents and grandparents and friends. So they must be sensitized, number one. Next influencer is school. So school teachers, in fact, I would strongly recommend when we say vitals, we say temperature, pulse, respiratory rate, BP. I think we should include BMI. BMI must be periodically measured at schools, and whenever we do under the school health programs, we should have a targeted interventions and follow up. I think it's a subtle issue, but we have to counsel them individually and make sure the impact of obesity in the long term, including the parents.
Right.
I think that is the very, because it is, as I already said, atherosclerosis starts from early. If you attack obesity, you can address 5 to 6 diseases. So I think the most important is your diet, exercise and environmental awareness. This will go a long way, and maybe we can take a policy decision of awareness every month. Like first Monday of every month should be awareness on the fitness and other things. And sir has suggested about playgrounds. I think physical activity must be a compulsory in all schools.
Curriculum, part of the
Yeah,
curriculum.
they should do some activity. It could be some athletic activity or a sports activity where they should do some exercise. I think we are already advocating gyms in government institutions. Like that, physical activity must be a must in all schools. Thank you.
Thank you so much, and thanks for those pointers actually. My last question to the last but the most important panelist, Joint Director NCD. So, for a program like Makkaletedi Martuvam, the MTM program, what do you think are the couple of two things that you would like to see as challenge that needs to be overcome, and also from the point of view, suppose say any other state who wants to implement a program like MTM, what are the two things that you will advise them that they need to do or they should avoid?
So thank you for this question. The MTM program we are facing mainly from bottom to top approach level. So you are reviewing all things through the tool and collecting the all data and all things. But frequent visit and frequent behavioral change by the WHV, you know. WHV, number of WHV, we should compare to other state. Ashas, one Asha for 1,000 populations. For example, 250 houses. They are frequently visited and change their behavior frequently. The quality of screening, that they are touch their heart and frequently and mingle with the family. So they are, and also not only the NCD, all work MCH and all works done by the year. Our need of WHV 63,000 for our population. We are managing only by 12,000, right? Yeah. In urban, peri-urban areas and slums areas, 20,000 population on WHV, no? So this is the main challenge.
So in that context, how do you think can we integrate early detection of NCD screening for childhood screening and NCD screening? Is it possible to incorporate into the MTM program?
Yes, we will plan to so more work already is done by WHO, you know. Right. Hypertension screening, blood screening and motivation for the cancer, breast, CSR.
Actually, the school teachers can themselves monitor. I think we can't expect VHN to do. We can identify the school teachers, Anganwadi people who can be part of the screening program.
Even though, sir, WHV also we give some training to the WHV, 1 or 2 points to maybe discuss with at the time of visit at the parent house to level. Yeah. From that to father and mothers and school and teachers training.
Yeah. Right. Thank you so much. Yeah, one
more point. Identify the children born to the mothers had gestational diabetes. Also, the child born with low birth weight and prematurity, and follow them closely to control these diabetes, these NCDs in future.
So perhaps not everyone, but a risk stratification can be done for whom the screening can be done early.
Yeah, another point what I missed in your previous question about the challenges in the urban centers is the easy availability of all the junk foods and the soft drinks. That and again in the urban areas, the children it is more affordable also. So they will easily buy, and these unhealthy food materials are available even in school canteens. So the action is required at the government level for policy formulation. Local level it will be difficult, that will be a big challenge. Thank you.
Also one point, sir, in our setup of institutional setup, our OP attending OP above 18 years percentage is more in government setup, right? And also RBSK we are concerned on the primary, the government aided schools. All private school students they are went to private hospitals. So we should include in the private monitoring and evaluation of private hospital also, the follow up.
Right. Thank you so much. I will ask Dr. Jerard to summarize.
So, there has been a lot of important decision points coming out of this. So, with the request to our Director of Public Health and Preventive Medicine, I think this topic is one of the most important topics in this conference, because as a recommendation, I think the audience and the panelists and everybody agree that we will take it as a policy to intervene into childhood NCD. So that will go as an important recommendation, sir. The other one is life course approach. How? Yeah. Okay. Yes, sir.
Yes. No, the school is the best opportunity for Kaushik's question. School is the best place where children can be screened. Already some of the components are already introduced into the RBSK system, where we measure BMI and brand them as childhood obesity or not. But this can be more focused one. Another one is, already we are, the government has recently asked all the departments to evolve a child health policy. Now it is the right time that we fit child NCD policy into the child health policy. So these are the updates which I want to measure.
Thank you, sir. Thank you very much. There is also a need for expert guidance, which we should take up after this conference. We should have the expert guidance meeting, so that we look at the community level screening also, because we have to take up the community level screening, look at the challenges in future. And I would like to congratulate also this Kerala experience, where you mentioned about healthy tiffin box campaign. So maybe our directorate should look into how they did that healthy tiffin box campaign and how they try to interfere in the school. And lot of things which Dr. Raghunanthanan sir said, like the Dept has got plastics, microplastics in your blood, limiting the screening time, sleep deprivation among our children, the youth and all that because of the screen time, and specific roles we have to do for the high risk children like babies who are prone for NCDs when they grow up. That is the low birth weight and children, the visceral fat issues and all. And FOAD, fetal origin of adult disease. I have noted down a lot of important points. I really thank our directorate, our director and everybody for giving me this opportunity to chair the session, because for my own learning I have taken down a lot of points. And my sincere appreciation to all the panelists and the moderator from UNICEF, Dr. Kaushik. I think this is going to be a lot of takeaway messages for us. We will be taking home a lot of good messages, and we should not end with this panel. After we go back to our respective job, we should sit up with our other works with the expert opinion and all that, and take it more seriously. By the next conference, I think somebody should be presenting on Tamil Nadu's experience, how we started doing something for the children NCDs. And I also thank Dr. Vinay, who was instrumental from behind the screen to give a lot of inputs to me also yesterday in the hotel, and like kind of like, I thank everyone, and the organizers, everybody, and please go and have a good lunch. Thank you.
Thank you, sir. I, on behalf of DPH Icon 2025, thank all the speakers for the insightful session. Now, we cordially invite the active and vibrant Joint Director Immunization, Dr. Vinay Kumar, onto the dais to felicitate our speakers. Chairperson, Dr. Jerard Maria Selvam, Additional Director, NHM. Moderator, Mr. Kaushik Ganguly, Social Policy Specialist, Child Survival, UNICEF. Put your hands together, please, everyone. Dr. K. Krishnaraj, Joint Director, NCD, Department of Public Health and Preventive Medicine, Chennai. Dr. Pradeep Kumar, Director, Health System Research, India Initiative, Kerala. Dr. Raghunanthanan, Director, ACS, Advanced Medical Research Institute, Chennai. Dr. G. Prakash, HOD, Department of Diabetology, Government Morgan Kumaramangalam Medical College and Hospital, Salem. Thank you, sir. Thank you all.